Welcome to the deep dive. Today, we're tackling a really intricate and pretty vital area of vascular surgery: fenestrated and branched endovascular aortic aneurysm repair, FBVAR for
All right.
short. If you've ever thought about how surgeons handle those aortic aneurysms, the ones that get dangerously close to arteries, feeding essential organs, kidneys, gut, even vessels to the arms and head, well, this is the deep dive for you.
Absolutely. And we're drawing on a key chapter from Rutherford's Vascular Surgery and Endovascular Therapy to really guide our discussion today.
Perfect. So most people have a general idea about aortic aneurysms, these bulges, these weaknesses in the aorta wall that can be life-threatening.
Exactly. But the complexity really ramps up when these aneurysms are near those critical branch vessels. Treating them gets significantly trickier.
Right. Traditional open surgery in those spots can carry pretty substantial risks, can't it?
It certainly can, which leads us to FBVAR.
And that's where FBVAR steps in. It's almost like a highly sophisticated internal plumbing job inside the aorta itself.
That's a good way to put it. Instead of major open surgery, you're using these specialized stent grafts. Think of them as fabric tubes supported by a metal framework.
And the key is these grafts have very precisely placed openings, or even little side branches built right in.
Precisely. That design is ingenious because it lets surgeons seal off the aneurysm while keeping blood flowing to those vital organs. No interruption.
So our mission today, using Rutherford's as our foundation, is to really unpack FBVAR.
Yeah, we want to go beyond just the definition. We need to understand the principles, the different kinds of devices, how the procedure actually works, and importantly, what the outcomes look like.
Basically a comprehensive but hopefully accessible overview of where FBVAR stands today.
Exactly. Let's get into it.
Okay, so let's unpack this innovation. Where did the idea for FBVAR even come from? It sounds quite revolutionary.
It really was an evolution, born out of necessity, you could say. The early work focused on abdominal aortic aneurysms, AAAs. Specifically, those where there wasn't much healthy aorta below the renal arteries, what we call a short neck.
Making it hard to get a good seal with a standard stent graft.
Exactly. So surgeons started experimenting. They began creating fenestrations, basically very precise holes in the graft fabric,
Holes lined up with the kidney artery.
precisely, to align with the renal artery openings. This let them extend the seal zone upwards proximally. Initially, they used uncovered stents just to prop those holes open.
So it started as a kind of on-the-spot modification for tricky anatomy.
That's exactly right. And as the tech evolved, they moved to using covered stents, bridging stent grafts with those fenestrations.
Which improved the seal and blood flow reliability.
Significantly improved both. Better seal, more durable flow to the kidneys.
Mhm.
Once that proved successful for infrarenal
So
AAAs,
it started applying it to more complex cases.
right, it was adapted for juxtarenal aneurysms right next to the renals, then paravisceral, involving the gut arteries, thoracoabdominal, spanning the chest and abdomen,
Yeah.
and even up into the aortic arch. A huge expansion.
That's incredible progress. Now, you mentioned fenestrations, but there seems to be a whole specialized language here. Can you break down some key terms? Scallops, fenestrations, branches?
Absolutely. Getting the term straight is fundamental. Okay, first, a scallop. Think of that as a semicircular cutout or notch, usually right on the edge of the endograft fabric, top or bottom.
Like a little scoop taken out.
Exactly.
Yeah.
Then there's a fenestration.
Yeah.
That's an actual hole cut into the body of the graft fabric. Its job is to allow blood flow to a branch vessel that the main graft body would otherwise cover.
Okay.
These fenestrations can be reinforced, sometimes with a little nipnol ring, like a tiny flexible grommet, to help it sit snugly against the bridging stent. Or they can be larger and non-reinforced.
Got it. Now, I've heard the term fenestrated branches used sometimes. Is that distinct?
That's a really good point to clarify. Historically, yeah, you might hear fenestrated branches, but the standard term now is just fenestrations when you're talking about these holes used with a covered bridging stent to reach the target artery.
Okay, so fenestration plus bridging stent.
Right. Now, a branched aortic endograft, or BVAR, that's different. This device actually has cylindrical fabric tubes built onto it.
Like actual little pipes coming off the main graft.
Exactly. They can be inside or outside the main graft body, pointing straight out or angled. They're designed specifically to target branch arteries, and these branches also need a bridging stent graft to connect them to the actual artery.
So, using your analogy, a fenestration is like a side exit door on the highway,
Uh-huh.
whereas a branch is like a whole built-in off-ramp structure.
Perfect analogy. And then, fenestrated branched endovascular repair, or FBVAR, is simply when one device cleverly combines both fenestrations and branches.
Mixing and matching based on the anatomy.
Precisely.
Okay.
Interestingly, there's still, ongoing discussion about whether branches or fenestrations are inherently better.
No clear winner.
Not really. Many experts feel both have pros and cons, and the best choice really depends on the specific patient's anatomy and, frankly, the surgeon's experience with each type.
Fascinating. So if FBVAR is the plan, where do these highly specialized devices actually come from? They aren't just lying around, I assume.
Definitely not standard or equipment. They generally fall into three main categories. First, you have physician-modified endografts, or PMEGs.
PMIGs.
Yeah, these start as standard, off-the-shelf endografts. The surgeon then meticulously modifies them by hand, right there in the operating room, often on the back table.
Modifies them how?
By cutting fenestrations, maybe even creating small, sort of rudimentary branches to perfectly match that patient's specific, often complex anatomy.
Wow, that sounds incredibly intricate. Requires deep knowledge of the device and the anatomy. What drives that approach? Is it common?
Well, the reasons are often twofold. One, the hospital might not have quick access to custom-made devices from a manufacturer.
Okay.
Two, in urgent or emergency cases, you just don't have the weeks it takes to get a custom device designed and built.
Time is critical.
Exactly. Experienced surgeons have figured out ways to modify most standard grafts. But, and this is important, the surgeon takes on significant responsibility doing this, especially outside of a formal research study.
Right. There's a balance between innovation and regulatory oversight for safety.
Absolutely. It's a fine line sometimes.
Okay, so PMEGs are one category. What's the second?
The second is custom-made patient-specific devices, or CMDs. These are manufactured by the device companies.
Based on the patient scans?
Precisely. Based on detailed imaging, usually that high-res CTA we'll talk about later. They map out the patient's aorta and branches, and the company builds a device to fit.
Tailor-made.
Exactly. These CMDs can have any combination of fenestrations and branches placed with incredible accuracy, and often they come preloaded.
Preloaded, meaning what?
Meaning a catheter and a guide wire are already threaded through the delivery system and sticking out through the fenestration or branch.
Ah, so it's partially set up already. That sounds like it would save time in the OR.
It definitely can make things much more efficient. You can use those preloaded wires to capture wires coming from, say, the arm to help guide things, or they can guide a sheath out from the groin access.
Makes sense. Are these widely available?
They are in many parts of the world. In the U.S., though, their use has often been more restricted, mostly within investigational trials. The Zenith Fenestrated device is a notable exception, being FDA approved. Common platforms for CMDs are based on grafts like the TX2 and Zenith designs.
Okay, so surgeon-modified, PMs, custom-made CMDs. What's the third option?
The third category is off-the-shelf devices. These are standardized designs.
Standardized? How does that work with unique anatomy?
Well, they aim to accommodate the most common anatomical variations. They might have fenestrations that can pivot slightly to line up with arteries at different angles, or they might have pre-positioned downgoing branches for the renal and visceral arteries.
So more readily available.
That's the huge advantage, yes.
Yeah.
Much quicker access than waiting for a custom device.
There are currently 4 main off-the-shelf FBVAR devices in U.S. trials: Cook's P branch and T branch, the Gore excluder thoracoabdominal multi-branch endoprosthesis, or TAM-E, and the Medtronic Valiant TAA system.
But the trade-off is they might not fit every patient perfectly.
Exactly. They're designed for a range, not for one unique individual. So greater accessibility, but perhaps less anatomical precision than a CMD in some cases.
Okay, that clarifies the device landscape.
Yeah.
Now, you mentioned different aneurysm locations, abdominal, thoracoabdominal, the arch. Do specific devices tend to be used for specific areas?
Yes, absolutely. The approaches and devices often vary by location. Let's start with abdominal aortic aneurysms, AAAs.
The main commercially available device in the U.S., specifically for FBVAR fenestrated repair in this region, is the Zenith Fenestrated Endovascular Graft, the ZFNN.
The one you mentioned is FDA approved?
Correct. It's designed for those AAAs with a short neck below the renal arteries. The main graft body uses a mix of scallops and different size fenestrations for the renal arteries and the superior mesenteric artery, the SMA.
Do they always need bridging stents with the ZFN?
Not always.
Yeah.
The smaller reinforced fenestrations typically do need bridging stents, but the larger fenestrations in the scallops often don't require that extra support. Then this main ZFNN body connects down to the iliac arteries using a standard bifurcated extension piece.
Are there other abdominal options, maybe used elsewhere or in trials?
Yes. There's the Vascutech Fenestrated Anaconda Endograft. It's not available in the U.S. currently, but used elsewhere. It can handle up to 4 fenestrations, often for perirenal aneurysms, those right up against the renals.
Hmm?
It has a unique feature, an augmented valley, which basically acts like a big scallop for the celiac or SMA. And then there's the Cook P-branch device, one of the off-the-shelf ones in U.S. trials. It has a celiac scallop, a fixed SMA fenestration, and then pivoting renal fenestrations.
Pivoting to adjust the angle.
Exactly. It gives some flexibility for variations in where the renal arteries take off. And importantly, the P branch often comes preloaded with wires and catheters to make accessing those fenestrations easier.
Okay, moving up the aorta then. What about paravisceral and thoracoabdominal aortic aneurysms, TAAAs? They sound even more challenging.
They are definitely more complex anatomically. And this is where custom-made devices, CMDs, really shine. They offer that unparalleled flexibility to put fenestrations and branches precisely where they need to be for that specific patient.
Tailored solutions again.
Right. And these CMDs can also have various preloaded options to simplify cannulating the target arteries. But we also have off-the-shelf options emerging here too.
Like which ones?
There's the thoracic branch, or T branch, from Cook Medical. It's based on their TX2 Graft platform and has 4 downgoing axial branches designed for the renal and visceral arteries. You connect these with bridging stents.
Okay.
And the other key one is the Gore Excluder Thoracoabdominal Multi-Branch Endoprosthesis, TMBE. This also has 4 downgoing internal branches for the celiac, SMA, and both renals. It uses Gore VBX balloon expandable stents as bridges, and it also comes with preloaded guide wires.
So good off-the-shelf choices becoming available even for these complex TAAs. Now, what about the trickiest part, maybe? The aortic arch, near the heart, feeding the brain. How does FBVAR work there?
You're right, the arch is uniquely challenging. You've got dynamic flow, constant motion from the heart, changes in the vessel wall stiffness. Repair here needs extreme precision.
What devices are used?
Well, the Cook Arch branch device is a customizable option. It can have scallops, fenestrations, branches, designed for deployment right up in zone 0, the segment closest to the heart where the main head and arm vessels come out.
Zone 0.
It uses a pre-curved delivery system to help aim the internal branches correctly. But placing the bridging stents usually requires surgical access from above, like via the carotid or axillary artery.
So often a combined endovascular and open approach.
Often, yes, for the bridging step part. There are other devices, too, in trials or development. The Relay MBS Plus from Bolton Teromo Aortic has 1 or 2 antegrade branches pointed with blood flow and a design meant to conform better to the arch curve. It even has internal tunnels to help guide wires for retrograde access, say from the carotids.
Retrograde against the flow.
Exactly. Then there's the Valiant Mona LSA from Medtronic. That's a single branch, off-the-shelf device for zone 2 deployment further down the arch, targeting the left subclavian artery usually. It has a modified cuffed fenestration and is preloaded.
And Gore.
Gore has the TAG thoracic branch endoprosthesis, the TBE, single branch again, pre-cannulated, pointing downwards or caudally. Also mainly for zone 2, but usable higher up in zone 0 or 1 if you combine it with surgical debranching, rerouting the head-arm vessels first.
It's really quite amazing how these are engineered for specific aortic zones and challenges. Now, clearly, before any of this happens in the OR, there must be intense planning. What does that involve?
Oh, meticulous planning is absolutely paramount. You cannot overstate its importance for FBVAR. It involves deep dives into the patient's imaging, getting precise measurements, deciding on the right device type, strategizing how to keep flow to every branch, and planning the specific techniques for cannulation and deployment.
And imaging is the cornerstone, I assume. What kind?
Absolutely. High-resolution CT angiography, CTA, with 3D reconstruction is the gold standard. If the arch is involved, you need ECG gating to freeze the motion.
Why CTA over MRA?
CTA gives better spatial resolution, shows calcium in the wall much more clearly, which really impacts planning and deployment. And MRA isn't quite as good for those details. And you absolutely need specialized post-processing software.
Software to do what?
To create a precise center line of flow path through the aorta. This lets you measure diameters accurately, perpendicular to flow, and pinpoint exactly where each branch vessel originates relative to that center line, accounting for curves. It's like creating a detailed 3D blueprint.
A blueprint essential for picking the right device and lining everything up.
Couldn't do it accurately without it.
So, using this blueprint, what specific anatomical features are you scrutinizing?
Several key things. First, the proximal seal zone. That's the healthy bit of aorta at the top where the graft needs to seal tightly to prevent leaks back into the aneurysm.
What makes a good seal zone?
Ideally, it should be relatively straight, cylindrical, parallel walls without much thrombus or calcium. And a core principle is You don't compromise the seal just to incorporate more branches. Secure sealing comes first.
How long does that seal zone need to be?
For FBVAR, we generally prefer longer seals than standard EVAR, often 20 to 40 millimeters. Also, sharp bends or severe angulation near where the visceral or arch branches come off can make planning and device alignment really tough. Generally, angulation over 45 degrees in those key spots is considered less ideal.
Makes sense. Trying to land a straight device in a sharp curve is asking for trouble. What else do you look at?
The branch vessels themselves are critical. Their size, any narrowing or stenosis at the origin, how twisty or tortuous they are.
Why does that matter?
It influences whether you choose a fenestration or a branch for that vessel, how easy or hard it'll be to get a wire and sheath in there and place the bridging stent. Very small or very diseased origins are challenging.
Okay. And what about getting the device to the target area, the access vessels?
Right, the access vessels, usually the iliac arteries in the groin, need to be large enough for the delivery systems, which can be quite big, 18 to 26 French.
That's substantial.
It is. And if the iliacs are very twisty or calcified, that can make it hard to advance the system smoothly and position it accurately. Sometimes you need upper extremity access brachial or axillary artery in the arm.
For getting wires down or accessing certain branches?
Exactly. Especially for downgoing branches or cannulating from above.
Mm.
Those arm vessels need to handle 6 to 12 French sheaths. Occasionally, if you need multiple large sheaths up there, you might even need a surgically placed conduit, like an artificial on-ramp, in the axillary artery.
It's clear this isn't just about the aorta. The whole vascular pathway matters, and the patient's overall health must be a huge factor too.
Absolutely. Careful patient selection and a thorough preoperative evaluation are crucial. You have to weigh the aneurysm rupture risk against the procedural risks, consider the patient's life expectancy, their other medical problems.
So morbidities.
Right. And you also have to factor in the time it might take to get a custom device, which can be weeks or even months. That delay has to be safe for the patient.
So what kind of medical workup is typical before FBVAR?
Well, these patients often have multiple health issues. So a comprehensive evaluation is key, tailored to their history. There aren't rigid universal guidelines, but common issues need assessment.
Like kidney function.
Yes, renal dysfunction is common, especially with TAAAs, and it increases risk. Coronary artery disease, COPD, those are also frequent. Interestingly, serious lung complications seem less common with FBVAR compared to open TAA repair, probably because you avoid the big chest incision.
That's a significant benefit. Now, you mentioned spinal cord ischemia earlier, a major concern. How is that risk assessed beforehand?
That's a critical evaluation,
Yeah.
especially for repairs covering long segments of the aorta. There's no perfect predictive test, unfortunately. Surgeons look closely at the planned length of aortic coverage.
And the collateral blood supply.
Exactly. If the collateral network to the spinal cord might be compromised maybe by previous surgery or the extent of the planned graft coverage, surgeons might consider staged procedures.
Staged how?
Maybe revascularizing key collateral feeders before doing the main aortic repair, trying to bolster the cord's blood supply first.
Huh.
Preserving flow to at least one internal iliac artery is also important for pelvic and spinal cord perfusion.
And for arch repairs, any specific pre-op checks?
Yes, for arch repairs, you definitely need CTA of all the great vessels coming off the arch, plus duplex ultrasound of the carotid and vertebral arteries
Why?
to check for any blockages, assess flow direction, and understand the potential stroke risk during the procedure.
Okay, so the planning is incredibly detailed. The patient is selected. Now we're in the OR. What are the key elements of the operative technique? Anesthesia, monitoring.
General anesthesia is standard, yeah. These can be long procedures, need controlled breathing for imaging. You'll usually have arterial lines, often in the arm, for continuous blood pressure monitoring, and they can double as access points if needed.
What about spinal drains?
Lumbar spinal drains are often used for patients deemed high risk for spinal cord ischemia, but it's an individualized decision weighing risks and benefits. And systemic anticoagulation, usually heparin, is essential to prevent clots forming on the wires and devices.
You mentioned hybrid ORs being valuable. Why?
A hybrid room with high-quality, built-in fluoroscopy imaging is a huge asset. Not strictly essential, but very helpful. You need a C-arm that can rotate fully around the patient 180 degrees to get those oblique and lateral X-ray views.
Views needed to line up the fenestrations and branches accurately.
Exactly. And radiation safety is a big deal. These procedures can involve a lot of fluoroscopy time, careful planning of the needed views, Using bony landmarks helps minimize exposure.
And fusion imaging, you mentioned that earlier.
Right. Fusion imaging is increasingly used. It overlays the pre-op CTA scan onto the live fluoro images, like a real-time 3D roadmap. It can significantly cut down on the amount of contrast dye needed, which is great for patients with kidney issues, and it can also reduce radiation dose. Sometimes markers are placed on the skin beforehand as external reference points too.
But you still need some contrast.
Usually, yes.
Huh.
Small puffs of contrast confirm vessel location, because remember, the aorta can shift a bit once you put stiff wires in.
It definitely sounds like this requires a specialized team and setup.
Absolutely. The technical skills for FBVAR are advanced, way beyond standard EVAR or TFAR. These are typically done in high-volume tertiary centers with dedicated resources and experienced teams. It's intricate work, manipulating wires and catheters in 3D using 2D imaging. Takes a lot of coordination and experience.
So walk us through the actual device delivery and deployment. How does it work, integrating those fenestrations and branches?
Okay, generally starts with femoral artery access in the groin, open or percutaneous. If you need arm access, brachial or axillary, that's usually done early, before full anticoagulation.
Let's take non-preloaded devices first, like the Zenith Fenestrated.
Right. For those, you usually need access in both groins. A large sheath goes in the contralateral side opposite the main device for catheters and wires to cannulate the target visceral and renal arteries.
Cannulate means getting into the artery.
Yes, getting access into the target branch artery. Sometimes, surgeons proactively place marker catheters in the branches beforehand via a small cut-down. The FBVAR device itself is then prepped outside the body, oriented correctly based on the plan.
Okay.
Then it's introduced over a stiff wire into the aorta. You unsheath it slowly, very carefully, watching the alignment of the fenestrations or branches with the target vessel origins on fluoro.
Can you adjust it as you deploy?
Minor rotational and up-down adjustments are often possible while some constraints are still on. Cannulation of the target vessels happens through that contralateral sheath using guiding sheaths, special wires, selective catheters.
Once you're in the target artery.
Once you access the artery through the fenestration or past the branch, you advance a stiffer wire further in, then slide a guiding sheet over that wire for stable access. The sheath size depends on the bridging stent you plan to use.
And you do this for all target vessels before fully deploying the main graft?
Usually, yes. Once all targets are cannulated and sheaths are in place, you fully deploy the main aortic graft body. Then, you advance the covered bridging stents through those sheaths into the target arteries.
Making sure they overlap with the main graft.
Crucial. Need good fabric overlap between the bridging stent and the main graft around the fenestration or branch origin. Often flare the proximal end of the bridging stent with a balloon for a good seal.
Then finish the distal part.
Right. If it's a bifurcated graft, you deploy the distal body and iliac limbs, similar to standard EVR.
Wow, that's an incredibly complex sequence. How do preloaded devices change things? Like the P branch.
They simplify parts of it, because the fenestration or branch already has a wire or catheter aligned within the delivery system. With the P branch, for example, after deploying the top part, you can often select the renal arteries by advancing a sheath through a dedicated channel in the delivery system, out through the fenestration over that preloaded wire.
So you don't have to navigate from inside the aorta out.
Exactly. It bypasses that step. And since you access the renals from the same side as the main device, you can use a much smaller sheath on the contralateral side.
Makes sense.
Once you have stiffer wire access in the renals, the rest deploying the graft fully, placing bridging stents is similar. Branch devices can also have preloaded wires. Sometimes a wire from a branch is snared from the arm access, creating a through-and-through wire from groin to arm.
That sounds useful for stability and guidance.
Very useful. Helps guide the main graft deployment and makes placing the bridging stents into the branches easier. This might happen before or after dealing with fenestrations or the distal graft part.
And finally, those aortic arch branch devices. Deployment must be even more delicate there.
Extremely delicate. Techniques vary by device, but generally you cannulate one or more supra-aortic vessels using wires from the groin or often direct surgical access to those neck or arm arteries.
Open access needed for bridging stents again.
Frequently, yes. Open exposure of a carotid or subclavian is often needed to deliver the bridging grafts connecting the device branches to the native head and arm arteries. There's a trend towards using both carotid arteries for access, allowing temporary clamping to potentially reduce stroke risk.
How is the main arch device deployed?
Usually over a very stiff wire, carefully placed in the left ventricle for maximum support. And many surgeons use techniques like rapid heart pacing or temporary balloon blockage of the vena cava.
To briefly lower blood pressure during deployment.
Exactly. To minimize the risk of the graft shifting or causing emboli at that critical moment. Often a preloaded wire from an internal branch is snared from arm access to get that through-and-through guidance, which is absolutely vital for accurate positioning in the curved arch.
Truly remarkable sophistication. Okay, let's shift gears. With all this complexity, what do the outcomes actually look like for FBVAR patients?
That's the crucial question, isn't it? We've moved beyond just proving it can be done. The focus now is on long-term results. How stable are the target vessels? How durable are the grafts? What about endoleaks?
We have more data now than just early case reports.
Oh, yes. We have larger cohorts from high-volume centers, multi-institutional registries, some with pretty decent long-term follow-up. And while we still lack big randomized trials comparing FBVAR directly to open surgery,
Which would be the gold standard.
right, but we have more well-designed observational studies that try to adjust for the fact that FBVAR was often initially used in high-risk patients unfit for open repair.
And when you account for that,
When you account for that, and when it's done by experienced teams in specialized centers, the data suggest outcomes are often comparable to open repair. And in some ways, especially short-term like perioperative mortality, hospital stay FBVAR might even have advantages.
that's very encouraging. Let's break it down by location. What about juxtarenal, pararenal, and type IV thoracoabdominal aneurysms? The ones mainly in the abdomen, but close to or involving visceral renal arteries.
For those, early outcomes have generally been excellent. High technical success rates getting the graft in, cannulating vessels, and pretty low early mortality reported in trials and big registries.
Any specific numbers?
Well, the pivotal ZFEN trial showed 100% technical success and only 1.5% 30-day mortality. Immediate renal artery occlusion was rare, and significant kidney injury wasn't common right after surgery.
That's impressive.
It is. Some single-center series might report slightly higher complication rates, but overall it's positive. Pooled data suggests perioperative mortality around 4%. Major complications like heart or lung issues can happen, and some degree of postoperative renal insufficiency occurs in maybe 11%, but needing permanent dialysis is much rarer.
How do the commercial devices compare to the physician-modified ones?
Recent large registry data, like from the VQI, suggests pretty similar perioperative mortality between approved fenestrated grafts and PMEGs in experienced hands. And interestingly, while temporary acute kidney injury after FBVAR isn't uncommon, it often resolves. The procedure seems feasible even in patients with pre-existing kidney disease.
Okay, what about longer term? How do these repairs hold up over, say, 5 years?
Midterm outcomes and branch durability look very promising too. In that ZFNN trial follow-up, averaging over 3 years, there were no aneurysm ruptures or conversions to open surgery.
0. That's fantastic.
It is. 5 years survival was good, freedom from major adverse events encouraging. Reinterventions were needed in about 22% over that time.
Reinterventions for what, mostly?
Most commonly for stenosis or occlusion of the stented renal arteries. But importantly, the actual patency, the openness of those renal arteries remained excellent, both primarily and after interventions, and kidney function held up well long-term.
Are those reintervention rates typical?
Yes. Other studies report midterm reintervention rates around 20–25%, sometimes for persistent endoleaks or issues with visceral fenestrations. Long-term mortality data beyond 5 years is still growing, but suggests good overall survival. One study showed very low aneurysm-related death at 8 years, though overall survival was lower because these patients often have many other health problems.
Right, they die with the repair, not from it. Okay, let's move up to thoracoabdominal aortic aneurysms. TAAs are really extensive ones. What are the outcomes like for FBVAR there?
Also quite encouraging, especially considering the alternative is massive open surgery. Pooled data show perioperative mortality around 3.7%. Perioperative renal dysfunction is higher, maybe 16% given the complexity, and spinal cord injury risk is around 2.5%.
Still significant risks, but perhaps lower than historical open repair data.
Generally considered so, yes. A key study on high-risk type 2 and 3 TAAs treated with FBVAR reported successful stenting of targets in about 96%, low rates of major endoleaks right after. Perioperative mortality was around 7% for type 2, 3.5% for type 3. Permanent spinal cord injury and dialysis rates were relatively low. More recent studies continue to support these generally positive early outcomes from experienced centers.
And the mid to long-term picture for these extensive TAA repairs?
We're getting more data now, It does seem that reintervention rates over longer follow-up are significant.
Higher than for the juxtarenal repairs.
Potentially, yes, given the greater complexity and length of aorta involved. However, aneurysm-related mortality remains reassuringly low. Some top centers report excellent long-term branch durability.
What affects how well the branches hold up?
Factors like the type of bridging stent used, how angled or tortuous the target artery was, and whether fenestrations or directional branches were used seem to matter. One major study showed high freedom from branch intervention at 1 in 5 years. Another showed good 3-year patency for renal and mesenteric arteries.
So while reinterventions happen, the branches mostly stay open and aneurysm deaths are rare.
That seems to be the trend. Overall mortality is higher due to comorbidities, but not usually related to the aneurysm repair itself in the midterm. We're getting better at understanding why reinterventions are needed, often type 3 endo leaks, component separation or fabric tears, or target artery stenosis occlusion.
What about other types of leaks?
Interestingly, some target vessel endo leaks seen right after surgery seem to resolve on their own over time, which makes you question if immediate reintervention is always needed. Type 2 endoleaks from side branches feeding the sac are very common after FBVAR and can sometimes prevent the sac from shrinking. Managing those is a whole other topic.
Okay, finally, the aortic arch. Given the challenges, what do we know about FBVAR outcomes there?
The data is definitely more limited compared to abdominal or TAA repairs. Much of it involves parallel grafting or PMEGs treating just 1 or 2 head arm vessels. Total endo-arch repair with branched grafts is technically feasible, especially in high-risk patients.
But the risks are higher. Stroke, dissection.
Those remain significant concerns, yes. A large global registry for a specific 2-branch arch graft reported about 13% 30-day mortality and 84% technical success. But early stroke rates were concerning, around 16%, and early reinterventions were needed in 10%, though no aneurysm-related death in the short term.
So feasibility shown, but safety and durability still under scrutiny.
Exactly. Other studies show varying results. Experience with PMEG sealing in zone 0 or 1 also exists, with reasonable technical success and mortality. One comparison suggested branched grafts might have slightly better outcomes than fenestrated ones in the arch, especially regarding neurologic events.
Understood.
We really need more robust, long-term data for arch FBVAR to understand its true role, refine techniques, and select patients appropriately.
Understood. It's clearly the frontier. Now, given all this complexity and the potential for issues over time, what kind of surveillance is needed after FBVAR? Is it lifelong monitoring?
Aggressive, regular surveillance is absolutely crucial. It's not a fix-it-and-forget-it procedure. Most clinical trials mandate strict follow-up protocols.
What does that typically involve?
Generally, patients get both a CTA scan and a duplex ultrasound of the stented visceral arteries, either before leaving the hospital or within the first month.
Why both CTA and ultrasound? What do they show?
They're complementary. CT is great for looking at aneurysm sac size, is it shrinking, and checking the overall integrity of the graft components. Duplex ultrasound is much better for detecting any stenosis, any narrowing, developing within those bridging stents feeding the branches.
Okay.
There's even a specific endoleak classification system proposed just for branch grafts to better categorize potential problems. And specific ultrasound velocity criteria have been suggested to detect renal stent stenosis, though they're still being validated.
How often is this surveillance done?
The typical schedule is often imaging at 6 months, 12 months, and then annually after that. But there isn't strong published evidence definitively proving one specific protocol is best. So it's often tailored based on the complexity of the initial repair, patient factors, and any findings on previous scans. Lifelong surveillance is generally recommended.
Makes sense. It sounds like FBVAR is truly groundbreaking, but also highly specialized. What are some of the key practice and regulatory issues surrounding it right now?
Well, there's definitely huge enthusiasm in the vascular surgery world for using FBVAR for these complex aneurysms. But, as we discussed, the limited commercial availability of fully approved devices for many complex anatomies is a major issue.
Which leads surgeons to want to use physician-modified grafts, PMEGs.
Exactly. There's a strong desire to use PMEGs. However, the Society for Vascular Surgery, the SVS, has put out a clear advisory statement. It says that for serial planned use of PMEGs, you really need formal institutional review board, IRB approval, and an investigational device exemption, IDE, from the FDA.
So routine use of PMEGs requires regulatory oversight.
Yes. Currently in the U.S., access to manufactured FBVAR devices for many complex cases is mainly through participating in clinical trials.
What about emergencies? Compassionate use.
The SVS statement does support a physician's ethical obligation to recommend any available treatment in an emergency if it's best for the patient. And that could include off-label PMA use. But even then, IRB approval and sometimes specific FDA or manufacturer okay is still generally required.
It's complicated.
It is, and it's critical to remember. Most of the strong evidence supporting FBVAR comes from highly specialized centers with deep expertise and high volumes.
So training and experience are key.
Absolutely crucial. Dedicated training at centers of excellence is incredibly valuable. The team's cumulative experience and appropriate adoption of new technology seem to be vital for getting good outcomes with these complex repairs.
So pulling this all together, FBVAR is a truly remarkable leap forward for treating complex aortic aneurysms. It uses this amazing toolkit of techniques and devices, surgeon-modified, custom-made, off-the-shelf, all aiming to exclude the aneurysm while crucially preserving organ blood flow.
That's the essence of it.
But it demands that meticulous planning, those highly specialized skills found in dedicated centers, and that commitment to lifelong surveillance. The outcomes look very promising, but clearly, ongoing research and long-term data are essential to keep refining things.
Precisely. It's a fantastic example of innovation tackling really tough medical challenges.
It really highlights this balance, doesn't it? The incredible technological push to treat complex diseases, but also that vital need for rigorous evaluation and ensuring patients who need it can actually access it. Looking ahead, what future advancements excite you? What might further refine FBVAR, maybe truly universal off-the-shelf devices?
That's the big question, isn't it? This field moves so fast, I definitely expect continued improvements in device design, making them more adaptable, easier to deploy, maybe lower profile systems too. I also think advances in imaging, both pre-op planning and intra-op guidance like fusion and AI assistance, will make procedures even more precise and safer.
And ongoing research.
Absolutely essential. We need more long-term outcome data, better strategies to minimize complications like spinal cord ischemia or those tricky endo leaks, maybe even incorporating biologic or drug-eluting components someday. It's a very dynamic field.
Definitely a lot to watch. If you, the listener, want to dive deeper into the specifics, the studies, the technical nuances we touched on, we really encourage you to check out that FBVAR chapter in Rutherford's Vascular Surgery and Endovascular Therapy. It's packed with detailed information and references. Thanks for joining us for this deep dive into the fascinating world of fenestrated and branched endovascular aortic aneurysm repair.